Now, what are the clinical presentation? That is irregular fever with chills and rigor, intermittent, type, fatigue, blackish discoloration of skin, enlargement of spleen and liver, that is splenohepatomegaly, progressive anemia, and low blood counts. Pancytopenia can also be seen with increased globulin level in the blood. Relapse is a Kala Azar case who experiences recurrence of Kala Azar symptoms with parasitological confirmation at any point of time after previous initial cure, that is 15 days of the treatment when the treatment regimen is less than 5 days. Uh, the diagnosis can be done by rapid diagnostic tests, and if suspicion of relapse or RDT negative with strong clinical suspicion is present, then refer to a medical college for biopsy from the spleen or bone marrow to look for LD bodies. Currently, the diagnosis is done by RDT or biopsy. And among the biopsy specimens, the splenic aspirated is the most sensitive with sensitivity more than 95%, followed by bone marrow and lymph nodes. Though lymph nodes are only present in very late in the disease, and the sensitivity of lymph node biopsy is 58%. RDT, that is the RK39 antigen-based kit test, it has some advantages, that is easy to perform, laboratory setting is not required, easy to transport, can be performed on a single prick blood. The results are available in 10 minutes. Disadvantages is cannot distinguish between current and past infection or in diagnosis of relapse or as prognostic test. This is a procedure that we have to take one single drop of blood and we have to add a chase buffer, and it is a kit test. So if there are 2 lines, it is positive. One important thing that RK39 tests may remain positive up to 24 months after treatment. Now, what is the treatment of Kala Azar patient? It is liposomal amphotericin B at a dose of 10 milligram per kg body weight. The total dose should not exceed beyond 500 milligram, and it has to be reconstituted with sterile water, and it has to be charged into 5% dextrose for transfusion. This is Ambisome, which is supplied by WHO with agreement with the government of India. And this is the steps of preparing Ambisome, and we must remember that we have to charge it in dextrose solution for transfusion. For each patient, start the infusion with 1 to 2 drops per minute, very slow test dose for a period of 10 minutes. And if the person develops no further reaction, then we have to give the rest of the solution within 2 to 3 hours. Infusion related reactions usually not very serious. Fever, chills can occur, lower back pain, nausea. If there is any infusion related reaction, we must slow down the infusion, observe the patient closely, and then we again start infusing. If there is any severe reaction, we must follow the standard operating procedure, and all adverse reaction must be reported. Anaphylactic reaction is very less, observed in less than 1 in 2,000 patients. Interaction, we all know that with nephrotoxic drugs and with corticosteroids and diuretics, there is chance of hypokalemia. Now, this is a very safe drug, and it has given in 1 month patient aged 1 month only up to 16 years, and in all adult patients, and even pregnant patient, this drug is very safe. Now, VL with HIV co-infection and its treatment. This treatment differs because the total dose is 40 milligram per kg body weight in 10 equal doses. That is day 1 to 5. Then the same dose has to be repeated on day 10, day 17, day 24, day 31, and day 38. Now, why VLHIV is important? The magnitude of VLHIV is 4 to 5%, and it is more prevalent in Bihar. VLHIV co-infection has major clinical, diagnostic, and epidemiological implication. The two diseases are mutually reinforcing. Poor treatment outcomes and higher mortality is present. Co-infected patients are more than 90% in more than 90% patients. There is relapse, and poses a new challenge to elimination effort of Kala Azar. Now, after giving liposomal amphotericin B, we may discharge the patient immediately. The fever will subside within the first week. This is followed by a return of appetite, weight gain, and the regression of spleen occurs at a rate of 1 millimeter per week. Now, PKDL is the case definition is a person of Kala Azar endemic area with hypopigmented macules, papules, plaques, or nodules with previous history of Kala Azar. And probable case is when we perform RDT and RDT becomes positive, that is probable PKDL, and it has to be confirmed by doing a skin slit smear or biopsy or PCR based test. PKDL usually appears first on the face and spreads to the other part of the body. It has a potential role in transmission of VL in the interepidemic period and may act as a reservoir. Potential threat to success of KA elimination program. These are the differentials, most commonly leprosy. These are the few images of PKDL showing the different type of skin lesions actually. Now, what is the treatment? This treatment is with miltefosine. If the person is weighing more than 25, then 100 milligram total dose in 2 divided doses for 12 weeks. If the weight is less than 25, then it's 50 milligram once daily for 12 weeks. And we must remember one thing is that it is contraindicated in pregnancy and lactation. So the choice is liposomal and amphotericin B, but the doses varies because it has to be given for 3 weeks actually. Now, these are the few pictures where the skin lesions has regressed. Before and after treatment.